I was working at Lower Manhattan Hospital, and I actually was working in urgent care. I was just, in Area B. Was not in the main bay, but we had a critically ill patient come in post cardiac arrest, had had two VFib shocks, and had been resuscitated. Like she had ROSC and was coming in, and was moving her all four extremities, but was not purposeful, was not responding to commands. And it sounded like the clinical scenario was that she was in her 40s, no medical issues, but she perhaps had had some kind of choking episode at lunch, and that's kind of what was thought to have led up to this. To kind of get to the important part, I was helping put in the airway. We were, bagging her, and as the nurse practitioner put in the gyroscope to intubate, the patient just like had a massive aspiration event. Just like I could see peas in the airway, and at that moment, they tried to suction, and very quickly the suction clogged, which oftentimes happens. And when I try to go to LMH, I always try to like set two suctions up in advance, but I hadn't had a chance to do that because I was working in urgent care, and so we realized we needed another suction, set up. So we set another one up and we suctioned, and she was desatting, and anesthesia was there. They tried it with a bougie, and it seemed like she had placed the tube, and we had lung sounds, but she was still desatting. We didn't have entitle CO2 waveform, and so we were concerned it wasn't actually in the airway. So they pulled it out, tried one more time, and the second anesthesia attending was able to get it with the glide scope. It was a 7.0 tube. And I think what I took away from that was just that, first of all, it's really important to paralyze patients. In that moment, the decision was made to not paralyze, because of her habitus, they were concerned, oh, maybe we may not get another attempt if we paralyze her. But especially because, she had choked, it seemed like that may have been part of the problem. And also, just the other lesson is to be prepared. And I wish I had been there 5 minutes early that day, because I would have gone in and done my typical thing, set up the suctions and stuff, and it wasn't set up. And that's exactly what we needed in that moment. And she's doing okay at this moment, but she got a bronch and is doing better. But that's what happened. I was helping, but I wasn't primarily taking care of this patient, and so it was hard to watch because it almost seemed like it was kind of spiraling, And one of the other posters with Dr. St. George, he talked about how, like, a failed airway it's almost like a tsunami. It starts to come upon you, and then before you know it, the stress in the room is through the roof. People are talking loudly. It's hard to know what's going on. It's hard to know who's in charge. And it was hard for me to tell, like, at what point do I jump in and, like, take over or help in a certain way, because I was primarily there not to take care of the patient. I was there just to help the providers who were. And so it was stressful. We talk. I think it's really important to debrief a little bit with the people who are in the room. I don't think we always do that well as EM providers, but I think it's important to talk about not just what could have been done better, oh, we should have had suction, or we shouldn't have, we should have paralyzed her, but also talk about how you feel. Are you okay? Do you need a breather? Like, go eat some food, whatever is necessary. And I also have like other like self-care things that I do. I have lots of hobbies, and I enjoy those and talk to people as well. If the patient, aspirates during an intubation attempt, don't like pull out your glide scope. That's actually what happened. Is they pulled the glide scope out and started started blindly suctioning, and you actually want to try to keep your view and suction, 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 and then if you can move the suction to the other side and hold it so you can actually pass, because they actually had a decent view. They had a grade 2 view of the cords. I was there watching, and I think it's possible we could have gotten the tube actually in the first pass despite the aspiration event if um, they had kept the glide scope in there, had kept the blade in place, and had suctioned and then held it. Obviously, in that moment, part of the concern that this provider had is, oh, maybe I'm gagging the patient. I need to pull this blade out and stop gagging them, which that makes a lot of sense, and that's probably why we need to paralyze her. But all that being said, if it does happen, I think it's important to keep your view as much as you can, and then suction, and then try to move your suction catheter over, hold it. It's called salad, I think is the technique's technical name, and you might be able to actually pass the tube, which I think probably we would have actually in the first pass if even in spite of the aspiration event.